Hello, and welcome to MRA's presentation for today, Hips and Knees, Replacements, Revisions, and Removals. First, let's get some housekeeping out of the way. Every reasonable effort has been taken to ensure that the educational information provided in this presentation is accurate and useful. Applying best practice solutions and achieving results will vary in each hospital or facility situation. A thorough individual review of the information is recommended and to establish individual facility guidelines. MRA does not guarantee the contents of this material and denies any implied guarantee of appropriateness of this material for any specific purpose. MRA is not liable or responsible for any loss or damage caused by the information presented in this material, including, but not limited to, any loss of revenue, interruption of service, loss of business, or indirect damages resulting from the use of this presentation. Furthermore, MRA does not guarantee that the content of this material will restrict disputes or differences of opinions with third-party payers, Medicare or otherwise, as to the specific dollar amount that is to be paid to the service provider. Copying, distributing, recreating, or any other unauthorized use of the content of these slides without the express written consent of medical record associates is strictly prohibited. Okay, that's out of the way. Hello, my name is Raylene Spicer, and I hold my RHIT, CCS, and CIRCC credentials. I've worked in the health information field for over 20 years, and I have experience in billing, payer relations, denials, failed claims, and of course, I have a special love for outpatient surgery coding, as well as interventional radiology and cardiology coding. We're going to start today talking about hips, partial and total replacements. We will talk about hip replacement, hip revision, removal of the hip prosthesis. We'll go over the history, anatomy, and implant types. And finally, we'll talk about procedure and diagnosis coding. Also, please keep in mind that any joint replacement can and will also be referred to as an arthroplasty, and I will be using these two terms interchangeably today. Let's begin at the beginning. What is a hip replacement, you may ask? Well, there are two types, a partial and total. Both types remove damaged bones and cartilage from the hip, which is then replaced by a prosthetic. The difference between the two is that a partial hip replacement only replaces the femoral head, while a total hip replacement must include the removal and replacement of the acetabulum in addition to the femoral head. We will go into greater detail of what exactly that means shortly, but first, let's have a little history lesson. The earliest recorded attempt at a total hip replacement occurred in 1891 with the use of ivory to create the femoral head. Over the years, techniques and implant materials have evolved, but the principles that are used today for hip arthroplasties were actually developed in the early 1960s. Some indications for hip replacements include osteoarthritis, which is the degenerative wear and tear on the joint that occurs over time. And this often results in a complete loss of cartilage and creates a painful bone-on-bone type of situation. Fractures, of course. Rheumatoid arthritis is where joints become deranged due to muscle atrophy and joint inflammation, and this often results in erosion of the bone. Osteonecrosis is where bone cells die due to a lack of blood supply, and there are also a number of childhood or congenital hip diseases. In later slides, we'll talk about the ICD-10 codes associated with these conditions. Our anatomy of the hip. Our hip is the largest, one of the largest joints in the body. It's a ball and socket joint. A synovial membrane surrounds it, and that lubricates the cartilage and allows for smooth movement. Ligaments connect the ball to the socket and provide stability of the joint. Here's a picture of what a normal, healthy hip joint looks like. And what we're focusing on today is the acetabulum of the pelvic bone and the head of the femur, which is indicated as the ball in this diagram. In the United States, there are two types of partial hip replacement devices, and they have different bearing surfaces, or they could have different bearing surfaces. Each type comes in a variety of sizes to fit each individual case. Partial replacements are either bipolar or unipolar. In both cases, the head of the femur is removed and a stem with a ball is implanted into the femur. In a bipolar hemiarthroplasty, the ball rotates on the stem. And in a unipolar hemiarthroplasty, the ball is attached to the stem, and then that whole unit rotates within the socket. The top image on our slide gives you an idea of how these two types operate differently from one another. Both bipolar and unipolar options can either have a metal ball or a ceramic ball, and our image on the slide shows us what a metal ball looks like. In a total hip replacement, not only is the femoral head removed and replaced with a ball, but the acetabulum is also carved out and replaced with a new socket or a cup. In the United States, there are 4 types of total hip replacements, and the differences are the different types of material that are used. So we have metal on polyethylene, which is the ball is made of metal and the socket is lined with polyethylene or plastic. Ceramic on polyethylene, the ball is ceramic and the socket is plastic. Ceramic on ceramic, that's where both the ball and the socket are ceramic. And ceramic on metal, which is a ceramic ball with a metal lining. The metal on metal implant was banned by the FDA in 2016. So what was happening was when the metal ball was articulating within the metal socket, tiny particles of metal were being released and then absorbed into surrounding tissues or even entering the bloodstream, which was making patients ill. So our description of a partial hip replacement: it's generally done for femoral neck fractures that can't be treated with other methods. The procedure itself usually takes about 2 hours. So first, access to the fracture is obtained. The femoral head is then removed with a bone saw. The femur is reamed and prepared to accept that stem implant. And then the implant is set into the reamed femur and fixed into place with bone cement. The incision is then closed and covered. Please be sure to check out this link to a short animation which illustrates both bipolar and unipolar hemiarthroplasties. These animations are concise, and I feel that they really help to illustrate the difference between these two types. Total hip replacement procedures typically take longer than a partial hip replacement. And again, the first step is to remove the damaged bone and cartilage. Just like in the hip, just like in the partial hip, the femur has to be reamed out to prepare it for the stem implant. The acetabulum of the pelvic bone is also reamed to achieve a smooth surface. Next, the socket portion of the prosthesis is placed into the acetabulum, and it's held in place with cement or screws. The stem is pounded into place in the femur. Out of all the major joint surgeries done today, partial and total hip replacements are typically considered the easiest to recover from. They usually require a very short hospital stay, and physical therapy is started immediately on the day of surgery. Most patients can get back to their pre-surgery activities within 4 to 6 weeks, and a full recovery is expected to be reached at the 3 to 6 month mark. Now let's talk about the diagnosis coding for hip replacements. Arthritis is the #1 reason for hip replacements, and the diagnosis codes are listed here. Be watchful for laterality and etiologies in the documentation to ensure coding accuracy. Rheumatoid arthritis is another common reason for a hip replacement. Check your documentation carefully when you're coding rheumatoid arthritis because the rheumatoid factor status is included in these codes. ICD-10, however, does allow for an unspecified code if that rheumatoid factor is not documented. Osteonecrosis is caused by reduced blood flow to the bones and the joints, which in turn causes death of the bone tissue. The classification is separated by the etiology of the condition, either being unknown, due to drugs, due to previous trauma, or another specified cause. And again, you want to assign the laterality. There are a variety of childhood diseases that could lead to a hip replacement, such as hip dysplasia, bone cancer, Legg-Calvé-Perthes disease, avascular necrosis, a slipped capital femoral epiphysis, osteomyelitis, and osteoarthritis. You can look up the codes for these conditions as necessary since they are not listed here. Traumatic head and neck fractures of the femur are found in the S72 category. As with all fracture coding, you need to look at your documentation to support the diagnosis and code to the highest level of specificity. Some other ICD-10 official guidelines you'll want to remember when coding fractures are that if a fracture isn't documented as being open or closed, then the default is to code to a closed fracture. If displaced or non-displaced isn't documented, then the default is displaced. And finally, when multiple fractures are documented, code to the severity. And of course, choose the appropriate 7th character of the ICD-10 code based on whether it is the initial or subsequent encounter and by the type of fracture as listed here. Remember, initial encounter does not necessarily mean that this is the first time the patient is being seen or treated for this condition. Rather, initial encounter means that the condition is under active treatment during the encounter. Refer back to Coding Clinic First Quarter 2015, page 3, for in-depth descriptions of 7th character assignment. Open fractures in certain categories further classify the open fracture and indicate the degree of periosteal and vascular injury and soft tissue loss. Categorizing open fractures based on this classification method helps to determine the overall prognosis based on the injury. This classification will be documented by the physician, but if it is not contained within the documentation, ICD-10 does allow for an unspecified code if that additional detail is not there. And here are the 7th character placeholders for open fractures where the open fracture classification is indicated. So B would be your initial counter for an open fracture type 1 or 2. C, your initial counter for an open fracture type 3A, 3B, or 3C, etc. I'll let you read the rest of that slide on your own. Pathological fractures are caused by an underlying condition, such as osteoporosis or neoplastic disease. The underlying condition should also be coded if it's documented. And if it's not documented, then an unspecified pathological fracture code can be used. Aftercare following a joint replacement surgery is coded to Z47.1. And don't forget to use a secondary code to identify the joint that was replaced, for example, hip joints. Aftercare codes are appropriate when the patient presents for follow-up after the initial surgery has been completed. And this would be the patient presenting in the absence of any symptoms or complications from the surgery. So for example, if a patient is seen in follow-up after their right total hip arthroplasty, they don't have any complaints, they're not having any symptoms, everything's great, it's just a follow-up encounter, the diagnoses would be Z47.1, aftercare following a joint replacement surgery. That's your first listed code. And then a secondary code would be listed as Z96.641, presence of right artificial hip joint. The aftercare phase for traumatic fractures is treated a little differently in that Z code would not be used for follow-up visits. Rather, you would code to the appropriate fracture code and use the 7th character of D or equivalent for indicating a subsequent encounter. Now keep in mind, we only talked about the most common diagnosis codes related to hip replacements, and it's certainly not an all-inclusive list. It's important to check your local MACs, your LCD policies for coding and billing guidance. And as always, you only want to assign codes that are supported by your documentation. Now let's talk about the CPT coding for hip replacements. First up is the partial hip replacement, 27125. Be sure to assign the appropriate laterality modifier. And for pro fee billing, if an assistant is used, you want to make sure to bill for that assistant with an 80 or an AS modifier, depending on their credentials. CPT 27130 is used for the total hip replacement, and this includes an autograft or allograft when performed. Again, don't forget about your LT and RT modifiers and your assistant modifier if applicable. When an acute fracture is treated with a prosthetic replacement of the femoral head, then you'll want to use 27236. There is an instructional note in the CPT tabular under code 27125 for hemiarthroplasty that directs you to code 27236 when a fracture is being treated with a arthroplasty. So check that out in your CPT tabular. Okay, now let's look at a sample op report for a total hip arthroplasty. The highlighted areas represent components that must be present in order to bill for the procedure. The pre- and post-op diagnoses here are both left hip degenerative joint disease. Our procedure is a hybrid left total hip arthroplasty. Indication, patient had progressive degenerative changes of the left hip. I'm not going to read through the entirety of this op report. I'm just going to touch on the highlighted portions. So here we have the description of the procedure. A patient was placed in a lateral decubitus position, left side up, bony prominences, well padded. Down we go to where the femoral neck osteotomy is carried out. The acetabulum is isolated with soft tissue retractors, and reaming carried out for a size 52 cup. The Richards Reflection 3 cup was then press fit with 2 screws with fair purchase. Now, I don't think we've talked about press fit just yet. So our options for setting the prosthesis can either be with cement, and that basically glues the prosthesis to the bone, or another option is press fit, and that's where that prosthesis is made of a porous material that is then screwed onto the bone, and the bone will eventually grow around that prosthesis, and it becomes a permanent part of that body. All right, so moving on, our T-shaped reamer is used to gain distal access. Broaching and reaming carried out for a size 12 stem. So we're preparing the femur for the stem. Then cementing was carried out. And after cementation had hardened, reduction maneuver was carried out again with good stability in all maneuvers. So just to sum up here, back on our procedure title, this was a hybrid total hip arthroplasty. And this procedure is hybrid because the acetabular cup was press fit with screws and the femoral stem was then cemented into place. So we've got two different types of methods being utilized for attaching that prosthesis to the body. So this is an example of an op report that supports billing for a total hip arthroplasty, code 27130. Next, we'll discuss total hip revisions and removals. Revisions and removals may be needed if the original replacement has failed in some way, such as a mechanical loosening of the prosthesis or an infection. These surgeries usually take longer because they are often more complex than the original replacement surgery. And the revision can include both the acetabular and femoral components, or just one or the other could be replaced. Common reasons for revision might be indicated. Common reasons that a revision might be indicated are recurrent dislocations of the prosthesis, broken or loose parts, infections, and periprosthetic fractures. And here we've got a couple of images. On the left, we've got a dislocation here. You can see that ball is nowhere near the socket where it should be located. And our other image is of a broken stem, so the actual prosthesis itself broke. So as I mentioned earlier, hip revisions can take several hours to complete. The surgeon starts by opening up the hip joint and removing all or part of the previously placed prosthesis. Then the joint is cleaned up so the new prosthetic can be inserted. Depending on the severity of the damaged joint or the presence of infection, the removal or revision process may have to be done in stages, in which case spacers might be used as placeholders until the infection is cleared or until that new implant is ready to be inserted. Recovery from a revision or removal typically takes longer than the initial replacement surgery. Just like in an initial joint replacement, physical therapy is started as soon as possible after surgery to get that joint moving. And it's typically going to take about 6 months to fully recover from a revision surgery. Recovery from a removal surgery will depend on how long that spacer had to be left in place before the new implant is placed. And once that new implant is inserted, then the recovery period follows that of the revision surgery. So again, that'll be approximately 6 months. Now we'll go over some of the ICD-10 codes for the common diagnoses for revisions and removals. Periprosthetic hip fractures are found in the M97 category. And according to Coding Clinic, fourth quarter 2016, a code for any underlying condition as well as a code for the fracture type, be it pathological or traumatic, should also be reported with that fracture code. So check that out for more information. This image shows a femoral fracture along the bottom portion of the prosthesis and then the resulting repair using a rod and cerclage bands to reduce that fracture. Those are the two images on the right. A broken or dislocated joint prosthesis, those codes will be found in the T84 category, and those are complication codes. Now, according to Coding Clinic, second quarter 2019, a dislocation of a hip prosthesis that has occurred due to a traumatic fall is still coded to a complication of the device, not to an injury code. It's a complication code. And then you'll also want to be sure to report the appropriate code to capture the circumstances of that traumatic fall from Chapter 20. So definitely check out that Coding Clinic for more information. Mechanical loosening of the prosthesis can be found in the T84.03 section. Mechanical loosening is when the implant may loosen from the bone, and that can cause pain and other symptoms. The body's reaction to the implant can also cause complications such as infection or inflammation, and these codes are found in the T84.5 section. You'll also need to use a secondary code to identify the infection. The revision codes 27134 through 27138 will be chosen based on the component or components that are revised. So if revisions are done on both the ball and socket, use 27134. If the revision is only on the socket portion, use 27137. And if the revision is only of the ball component, then use 27138. Grafts are included in all three of these procedures if it is performed. A simple hip prosthesis removal is captured with CPT code 27090, and it's typically only billable as a standalone procedure due to the separate procedure designation in the CPT tabular. Code 27091 would be used for a complicated removal, which would include inserting spacers if that is performed. Physician documentation is going to guide you on whether or not you choose a simple or a complicated removal code. And if that documentation is not clear, then you should query your provider. And finally, when a previous hip surgery is later converted to a total hip arthroplasty, code 27132 should be reported. CPT Assistant September 2017 tells us that this code applies to any previous hip surgery in the patient's surgical history in which a skin incision was made. That is, except for a total hip arthroplasty, of course. So anytime the patient has had a previous surgery that then results in a total hip arthroplasty, you'll want to use 27132. So that's a fracture fixation, a hip pinning for a slipped capital femoral epiphysis, an osteotomy, or even a hemiarthroplasty. Anytime any of those surgeries were done in the past, and now the patient is having a total hip arthroplasty, code 27132 is the one you use. Removal of any old hardware is going to be included in this code. It's considered integral to the procedure. This code, 27132, should also be used when a staged procedure is being performed, as is in the case of removing a previously placed spacer and replacing it with the permanent prosthesis. For example, once a prosthesis-related infection has cleared. So this situation is further detailed in CPT Assistant December 2008. And in this case, don't forget to append modifier 58 if the conversion procedure is being performed within the global period of the prosthesis removal procedure. All right, now let's transition over to knee replacements, partial and total. Again, we'll talk about knee replacements, knee revisions, removal of the knee prosthesis, history, anatomy, and implant types, and of course, procedure and diagnosis coding. Partial and total knee replacements involve removing damaged bone and cartilage from the affected knee and then replacing these surfaces with a prosthetic implant. So there's a great article in Coding Clinic for HCPCS, third quarter 2021, so quite recently, that puts this simply by just stating that a knee replacement could actually be referred to as a knee resurfacing, since it's the surfaces of the involved bones that are reshaped and then capped with a prosthesis. Now, this is in contrast to the hip arthroplasty procedures that we just talked about, in which the entire head of the femur is removed. So in knee replacements, no, the entire end of the bone isn't being removed. It's just being reshaped and then resurfaced or capped with that prosthetic. Now, typically a total knee replacement would include removing and replacing the lower femur and the upper tibia and the patella, and a partial replacement could include any of those components, but not all three. The partial knee replacement is a minimally invasive surgery. The first implant device was introduced in the 1950s, but the first partial replacement wasn't successfully performed until 1982. The total knee replacement technique evolved from the total hip replacement design, and the first total knee replacement was performed in 1968. Advances and improvements are occurring on a continual basis, and they include the development even of gender-specific implants, which is really interesting. So some common indications for a partial or total knee replacement are similar to those necessitating hip replacements. They include osteoarthritis, rheumatoid arthritis, osteonecrosis, avascular necrosis, as well as other knee pathologies. And some anatomy of the knee. It's considered a hinge joint because the movement allows the leg to extend back and forth like a hinge would. It is the largest joint in the body. The knee structure includes the femur, the femur, the tibia, the fibula, and patella, the articular cartilage, the medial and lateral menisci, ligaments, and tendons. All the three major compartments of the knee are the medial, which is the inside of the knee, the lateral, which is the outside of the knee, and the patellofemoral compartment, which is the front of the knee between the kneecap and thigh. And here we have an illustration of the anatomy showing all of our components, and then the picture on the right demonstrates that hinge action of the knee. Now let's talk about the implants. There are currently more than 150 different knee implant designs on the market. They are made from metal, plastic, and ceramics. The implant can be secured in place by cementing or cementless or a hybrid fixation method, some combination of both. The hybrid fixation is where one component, which is usually the femoral component, is cemented, and another component is press fixed or press fit into place. And we already discussed what press fixed means. So that's where that prosthesis is not cemented at all. Rather, it's made of a porous material that is screwed onto the bone, and that bone eventually will grow around that prosthesis, permanently adhering it to the body. A total knee prosthesis replaces both the medial and the lateral compartments, and a partial knee prosthesis replaces only one of those compartments. Partial knee replacements are a three-step process. They typically take an hour or less to complete. First, the surgeon opens the joint and removes the damaged bone and cartilage. Then the implants are cemented or press fixed into place. And finally, a plastic liner is inserted between the two components to create a smooth gliding surface. Typically, the patient is in the hospital for 1 to 3 days, and just like in hip arthroplasties, physical therapy is started as soon as possible, sometimes even on the day of surgery. Most people are back to their pre-surgery activities within 6 weeks. That is a fast recovery. Total knee replacements are more involved, and therefore they take longer, typically about 2 hours. Again, the damaged bone and cartilage is removed from the femur and tibia, but this time both the medial and the lateral compartments are addressed. The prosthesis is either cemented or press fixed into place onto the cut ends of the femur and the tibia. A plastic spacer is then attached to the metal tray on the tibial component, and that's where the femoral component will rest. Depending on the condition of the underside of the patella, the surgeon may decide to remove it and replace it with a patellar button, which is cemented into place. And finally, once all of those components are in place, the knee is working smoothly, then the incision is closed and covered. Just like with hip replacements, there are many videos online if you're interested in seeing an animated or live view of a partial or total knee replacement. This is a good one. It's short, it's about 3.5 minutes, and it gives you a nice overview of a total knee replacement. The road to recovery for knee replacement. They've evolved a lot over the years. So recovery is similar to that of a partial knee replacement. The patient may be able to go home the same day, or sometimes they stay for a day or two. Physical therapy is started right away, and total recovery typically takes about 12 weeks. The diagnoses necessitating knee replacements are similar to those for hip replacements, with the number one most common indication being osteoarthritis. That's code to the M17 category for knees. Rheumatoid arthritis is another common diagnosis, and that's coded to M05 through M06, those categories. And again, check your documentation for that rheumatoid factor if it is present there. Other knee pathologies that may warrant a knee replacement are pain and instability, which code to M25.56 and M23.5 respectively. Again, aftercare. The aftercare code is Z47.1. Be sure to use a status code in the Z96.6 section to identify the presence of the artificial knee based on your laterality. And remember, traumatic fractures, aftercare, that does not get that Z code. That you're going to code to the fracture with the appropriate 7th character indicating a subsequent encounter. Okay, just a couple of final reminders. We just discussed a few common diagnoses associated with these procedures, but keep in mind there are lots of others. It's important, again, to check with your MACs to gain further guidance on coding and billing for these procedures and covered diagnoses. And of course, as always, your documentation has to support the diagnoses you report. Okay, now on to the procedure codes for knee replacements. We have 2 codes, one for partial and one for total. Partial knee arthroplasty codes to 27446. This procedure includes the knee condyle and plateau in either the medial or the lateral compartment. It's partial because only one compartment is being addressed. A total knee replacement codes to 27447, and this includes the medial and lateral compartments. A total knee replacement, the code for the total knee replacement, 27447, also includes patella resurfacing if that is performed. Computer-assisted navigation is often used during total knee replacements to aid in alignment and positioning of the implant. So in this case, a preoperative 3D template of the knee is created and then utilized during the procedure. So image-based navigation will utilize fluoroscopy, and that's captured with code 0054T, or with CT or MRI, and that would be captured with code 0055T. Image-less computer navigation is also an option, and rather than obtaining preoperative images of the knee, this requires registration of knee landmarks intraoperatively using a special software, and algorithms within that software then help to determine positioning of the prosthesis. That service is reported with add-on code 20985. Okay, now let's look at a sample op report that supports billing a total knee arthroplasty, 27447. Now again, the highlighted areas are indicating documentation that is required to support billing the procedure. So we have a pre- and post-op diagnosis again of right knee degenerative joint disease, and in this case it's severe. And our procedure is going to be a right total knee arthroplasty. Now down in our description, the patient's right lower extremity is prepped and draped in that usual meticulous, sterile fashion. A drill is used to drill the distal femur. So this was enlarged, irrigated, suctioned, and the intermedullary guide placed to full length of the femur. So this is a device that's being placed on the bone to help guide the cutting of it, the resurfacing and reaming of that femur. So the distal femoral cutting guide pinned in the appropriate height. Distal femoral cut was made. We then measured the femur using the anterior referencing guide. Size 7 was appropriate size. We marked the distal femur and impacted the cutting guide into position, and the anterior and posterior chamfer cuts were then made. A rongeur was used to remove additional osteophytes. The drill was used to drill the center portion of the tibia. So now we addressed and prepared the femur. Now we're preparing the tibia. The proximal tibial cutting guide placed at the appropriate height. The proximal tibia was then cut while protecting the collateral ligament. The medial side measured approximately 9 millimeters and the lateral side 8 millimeters due to bone loss from arthritis. The patella was then measured. Cutting guide clamped in place, patellar cut was made. We drilled the peg holes and placed the tibial trial component. We then drilled the distal femur and removed the trial components. So now all the trials are being removed from the femur and the tibia. Bone plugs placed in the proximal tibia and distal femur. The cement was vacuum mixed, and when it reached appropriate consistency, the knee was thoroughly dried. Then the tibial tray was cemented into place. So now here's our tibial component being cemented into place. Excess cement was removed. Polyethylene was locked into place. The femur was then impacted into position, and the knee was taken out 30 degrees of flexion with uniform compression placed across the components. Then the patellar button was cemented. So ultimately here we have this op detailing the resurfacing of all of the components of a total knee arthroplasty. The distal femur, the proximal tibia, both the medial and lateral compartments, and then we also had resurfacing of the patellar button. So this all codes to and supports reporting 27447, and obviously appending our laterality modifier for that to go out on the claim. Okay, now let's move on to knee revisions and removals. Just like with hip revisions and removals, if a previously placed knee implant fails, then a revision and/or removal may be necessary. It's inherently more complicated than the initial replacement, so it's going to take longer to complete, typically 2 to 3 hours. The most common reasons for a revision or removal are loosening or breakage of the prosthesis or any of the components, infection, or a periprosthetic fracture. The procedure itself includes removing the old implant components and cleaning out all of the cement, being careful to preserve as much of the native bone as possible, and then replacing it with new components. The patella may be resurfaced, and if only a removal is done, if only that old prosthesis is taken out, spacers may then be inserted until the new implant is placed at a later date. Finally, the joint will be washed out and the incision will be closed. A revision on an infected knee will usually be done in 2 steps because a course of antibiotics would need to be administered between the removal and reinsertion of a new implant. Knee revision recovery is similar to the original replacement surgery at about 12 weeks. Removal recovery will depend on how long it takes to replace the old implant with the new one, but once the new implant is in place, recovery is typically about 12 weeks from that point. The diagnoses indicated for knee revisions and/or removals will be similar to those for hips. So we have periprosthetic fractures, which for the knees code to the M97 category. Broken and loosening implant components code to the T84 category. And go again, that is a complication code. As is infections and inflammatory reactions, coding to T84.5. The selection of your CPT code to capture the revision of a knee arthroplasty depends on how many components are being revised or removed. I'm sorry, we're just talking about revision, so revision here. If only the tibial or the femoral components are revised, or if the polyethylene liner is removed, then 27486 is reported. If both the femoral and the entire tibial components are revised, then report 27487. Allograft could be used to pack any significant bone defects, and this is included in both of these codes, so it's not separately reportable if it's done. Removals code to 27488, and they will include the insertion of a temporary spacer if that's performed. And here you can see what that spacer looks like. It's just a block that's bridging that gap there between the femur and the tibia. Boy, and that's it. This went fast. It's been fun, you guys. Thanks so much for joining me today. I hope you found this presentation informative, and I hope you're encouraged to go down some internet arthroplasty rabbit holes and learn more about hip and knee arthroplasties, and check out some of the numerous videos and graphics that are out there that will help enhance your knowledge. As always, please let us know if you have any questions. Here are some references to get you started down those rabbit holes. So hips and knees, and again, CPT Assistant, Coding Clinic for HCPCS, and Coding Clinic for ICD-10 are all amazing resources. And I highly recommend you refer back to those whenever you have any questions regarding what a particular code entails, or what services may or may not be included in it. All right, thanks again. Have a great day.